Hello, everybody, and thanks again for joining us for our next podcast in our Reducing Venous Depletion series. Today, I have a great pleasure of welcoming Matt Ostroff and Connie Turgenti to this call. Really looking forward to hearing what they have to talk about. We have two great clinicians here that I am sure are going to have a phenomenal conversation that's really going to make us think. Matt Ostroff is a Vascular Access Coordinator and Lead Clinician APN at St. Joseph's Medical Center. I'd like to take this time to welcome him and welcome Connie, who is Vigon's National Clinical Educator. Welcome to both of you, and thank you for everybody for joining us at home. At this point, I'd like to turn it over to Connie so she can begin talking with Matt.
Thanks, Steve, for the introduction. Matt, I really want to thank you for taking time out of your busy day, but also congratulate you for all you're doing to help, move our specialty beyond just PICC placement of the upper arm, and for being open-minded for so many devices. And I'm wondering if you could tell us a little bit about what inspired you to consider the infamous extended dwell peripherals for your patients in New Jersey.
Connie, thanks so much for the opportunity to participate in this. Vascular access is just something I happen to love. And I remember when I was in acting school, my teacher said, if you can do anything else, do not do acting, because you have to put your whole life into it. And when I found vascular, there's just nothing else I'd want to do. So my journey kind of evolved into the extended dwell because I wanted to de-escalate a lot of our patients when they didn't require, PICC line or central access. And I wanted a solution that could get us through 1 to 2 weeks, maybe even 3 weeks, without going to a midline, without going the extra mile to putting in, a entire, procedural device. So, we got really good results from our ultrasound guided peripherals. And one of the things that kept, running through my head was, what about a PICC line material? Why aren't we putting like a PICC line as a peripheral IV? And a couple of times I had patients with really small vessels. And what I would do was I would take the, pediatric lines, either a 1.9. I even took a double lumen 2.6 French catheter once, and I cut it to about 6 centimeters, and I put it in the forearm, and I got great results. And it just so happened I was hanging out with actually the Vigon rep came to my hospital, and I kept shooing him off because I was so busy. And eventually one day I went down and I was like, look, what do you have to show me? Because it's hard with sales and being busy. And he pulled out the LeaderFlex catheter, and I touched it. And I said, wait a second, what is this? And he said, well, it's the same material as our PICC lines, our pediatric PICC lines, but we made it into a length suitable for adult and pediatric peripheral use, and that was it. And what happened, the most ironic thing was, I had a sickle cell patient upstairs who had very tiny veins, and she needed a line for blood draws and pain medication infusion and fluids. I took the LeaderFlex from him, brought it upstairs, opened it at the bedside, and put it in this patient. And she got through her entire week of therapy with blood draws and infusion, and that's what sold it to me. It's all about the right timing when someone opens your mind to seeing something that you're not used to, something that's different, but you have to always remember that we're working for the patient. We're not working for us. It's not what works in our hands. It's what works in the patient. And the second that I saw that work, the game was over, and I just started really believing in the extended dwell peripheral. But I did believe that it had to be a soft material, and it had to be put in a very delicate manner, and that's how I kind of fell in love with them.
Wow, yeah, that was definitely an aha moment for you. I'm sure you've read Dr. Helm's publication, The Accepted but Unacceptable Failure Rates of Short Peripherals, right? And for me, it was like, oh, okay, a thermosensitive polyurethane. We have, manufacturers, clinicians that'll say, well, peripherals are polyurethane and that they're thermosensitive, but it's still it's stiffer. So it really makes a huge difference.
And in defense of the clinicians, I would say where the Helm article misses the target is, part of these statistics are from patients that are in the ER that the emergency nurse saves the day, gets something in the finger. Well, of course, that IV in the finger or the IV in the bend of the arm or wherever they're getting these lines are going to fail. So the question is, is our IV failure rate so poor, or are the situations that our nurses are placed in without ultrasound, without a vascular specialist, so complicated that they couldn't even succeed if they tried? And so I do think that there is a part of the story that's not being told, which is, why are they failing? Well, look, they were in cardiac arrest, and for some reason the only thing the paramedic could get was this in the pinky. Well, that became a database of a failed, IV by the time they got into the ER. Things like that, where it's not the clinician's fault. So I think there's a mix. We have, because if you look at peripheral IV failure in the hands of vascular specialists, you wouldn't get close to those kind of numbers. So the real question becomes,
that's true.
Where is the problem? Is the problem with nursing, just not having the tools and the training, or is the problem that we have chronically ill patients that are coming back to the hospital with very complicated vasculature, and they require a specialist? You know what I'm trying to say, Connie?
Absolutely. No, totally agree. I think patients, like you said, are sicker and sicker. And then we have peripheral IVs in the hands of every nurse, the generalist, right, placing these devices, and they don't think like we do, and they don't have the tools that we do. So I think, if we look at the failure of generalists, and I think Clara Carr did some research on that, the incidence of failure was absolutely higher in the hands of generalists compared to specialists. And how do we get, Matt, this is our next project, how do we get administration in every hospital across the United States to understand the value is within our specialty, of having vascular access specialists with these tools in their hands?
I mean, the way that I sold it in my program was very, very simple. If you have a patient that was not able to get their CAT scan because they did not have a line, and you had to call the vascular team. If there wasn't a vascular team, what would happen? Well, they already went down to CT. They weren't able to get their scan. They were sent back to the floor. So now they're off the schedule, and they're going to wait till tomorrow. So you're looking at a minimum of $2,000 to $3,000 a night in the hospital. Right. Now you bring your IV team or your vascular specialty team, and they come, they put the IV in, they get the CAT scan, the diagnosis is made, they start treatment that day. You now save $2,000 to $3,000 a day on that one ultrasound-guided peripheral IV. So the way that I sold it was tracking, why are we placing the devices and what are they equaling? Like what is the catalyst here? Did they get their test? Did they get to surgery sooner? Did they get downgraded from the ICU because we could remove their triple lumen? That's how to do the financial sell, is not to show volume, but to show impact. And I believe that hospitals across the country, if they could see the impact of what getting access provides, and as well as the decrease in supply usage, because you've all seen the nurses that carry 3 or 4 IVs to the patient, and you ask them, oh my God, how many lines do we need? Should we put in a triple lumen? And they go, no, I just, I might need a couple to get this. So, but when you do the math, that is a lot of money of just wasted supplies.
Yeah, definitely.
So I think that's how we have to do it. We need to, as a vascular access community, put all of our data together. And there's a national registry for central lines. I would love that registry to extend into peripherals. I think that registry could change the country's practice and implement ultrasound-guided IV teams with peripheral data on a national level of cost savings, of impact, of what the procedure is equaling. And that's the way we have to do it. We have to have data. We all have the stories.
Definitely.
Need data.
I would have to agree. And I think too, though, and take that data to legislation to get those nurses in every hospital, absolutely, for sure. So I did also want to ask you, circling back to the EPIV and saving those dollars, right? Because we burn through those dollars with our short peripherals. Nurses try 3 times. Are you placing the EPIV in all patient populations?
So that's a great question.
Mhm.
One of the most beautiful things that I love about coming to work. I remember when I was an ER nurse, one of the attendings told me, "You can't go to Vascular Access. You're going to be so bored. All you do is the same thing every day." And they're 100% right. We do the same thing every day, but when you do the right thing for the patient, it's not the same thing. It's a different vein. It's a different depth. It's a different angle of insertion. It's a different kind of comforting at the bedside to get your patient to agree to allow you to perform the procedure, and it becomes an art. So to answer your question, if the patient is a outpatient infusion for a CT scan, they're just going to get our, run-of-the-mill, regular, long ultrasound-guided IV. If the patient is on the floor and they're going to be here for, 2, 3 to 5 to 6 days, they're going to get an extended dwell peripheral IV. If the patient, is going to be here for a month and require multiple things with extremely difficult access, they're going to get, either a central line, an axillary or a jugular, or even, a tunneled catheter if we have to do that. So what I love about our program is we're able to triage the device based on the patient's presentation. So to answer your question, does everyone get an extended dwell PIV? No. Do the majority, the 85% of our patients get that? Yes. But if you don't need it, there's two edges of the sword, right? Where the extended dwell peripheral does cost more than your average IV. So, you can make the argument, well, I could use a long 22. Why would I use a 6 centimeter, or a 4 centimeter extended dwell? Well, the difference is, 1, you're putting in a different material that's going to last longer. 2, you're putting in a softer catheter that's going to be more gentle to the vein. And you're going to get a longer dwell time based on the type of catheter. We see this with PICC lines. Not just because they're dumping into a large vein, but because of the material and the softness. There's no, stiffness at all in these PICC lines, and that's what we're getting now from the extended dwell IV that I use, the LeaderFlex catheter. So, 85% of our patients will get that so that they can get their blood draws too. When you add in the phlebotomy sets and the time of your tech to draw the blood, that adds up too. It's not just the cost of the IV. So about 85 extended, and the rest, whatever they need at that time.
Wow, that's awesome. I think too, there's all this controversy over extended dwells, right? Like, made up names and, just all those kinds of comments we hear. But I think what we're forgetting, for me as a clinician, is that why are we automatically going to the upper arm power injection, like automatically, right? We're not even thinking. It becomes routine where I feel like I want to preserve the veins of the upper arm for when that patient really needs it. Because if you need, IV therapy, antibiotics for 1 to 2 weeks, why wouldn't we put in that softer material in the forearm versus automatically going to the upper arm and risking, thrombosis and things of that like that. And that's the kind of I think for me, the message that we have to consider.
Yeah,
right? Those
Connie,
other devices have so many complications.
Connie, you're 100. You know what I love? You're 100% right. The problem is we work in silos. We have our pediatric teams, we have our adult teams, we have our PICC teams, we have our vascular teams, we have our central CVC teams. But when you combine the information, our renal population alone has taught us vessel preservation.
Yeah.
So we are
absolutely.
so careful on these patients of what veins we're going to access, where we're going to do it. We follow guidelines. Yet on anybody else who's not going to have a fistula place, we'll stick anything and get DVTs and not worry. So I think we need to apply the same guidelines that we use on renal patients with non-renal, in the sense of, and let me just explain what I'm trying to say, is that we should start in the forearm if it's appropriate for that intended therapy, so that, exactly to your point, we can save the upper arm veins for when we need that, because people are living longer. People are getting cured of diseases. It's no longer you go in for the big one and that's your hospital stay and you either die or you live and then you die at home. You're going to be hospitalized 5 to 6, and our chronic people are just in and out, in and out, in and out. So you have to think the way we think with renal patients 10 years down the road. We need to think of all of our patients as 10 years down the road, even our pediatrics. You can't
Absolutely.
be getting excited about midlines in kids. If you mess up their upper arms as a child, what's left as an adult?
Absolutely. I totally agree.
We have to be so careful, and I believe that part of our documentation should be a justification in why we chose the line we chose, why we used the vein we used, and what the intended purpose is, so that we can learn from our mistakes.
Yeah. Absolutely. 1 billion catheters, right, peripherals are purchased or placed a year. And exactly to your point, as a pediatric nurse, I started out in the NICU, and we had the bowel obstructions and the really complex kids who then, when I went to the IV team, I saw as pediatric patients. And you nailed it. They get centrally occluded by the time they're 6. What does that mean for them? So I agree. Maybe that's another one of those put on the professional to-do lists. Is there...
Connie, it's really interesting. We use that number, over 1 billion peripheral IVs. I wonder what that number would turn into when the majority of the population starts using the extended dwell peripheral. How many IVs we will take out of that? I guarantee you we could at least cut the usage down by a third.
Yeah, I would agree.
700 million.
Yes. Claire Ricard wrote a paper, and she talks about the cost of peripherals, the hours that it takes, and the healthcare costs. And that's with an average of 2 days of dwell. What would those numbers look like if we got 4, 6, 8, and 10 days of dwell?
It'd be unbelievable.
The dollars saved would be unbelievable. Absolutely.
I mean, what we're getting at our hospital, we're getting our patients through their treatment. We're getting them from stick to discharge with our extended dwell peripherals. It's changed the whole game. And let me give you another patient population that we don't usually think about. We have a very high-risk pregnancy population at my hospital, and they get put on long-term mag drips. We used to always go through peripherals or put in PICC lines. We put in these extended dwells, and they're going 30, 40 days for these patients.
Wow. Yeah, PIV.
Yeah, extended dwell PIV.
Amazing. Yeah.
It's just, I don't think anybody thought of it. And I think the other challenge out there is ultrasound-guided IVs are more difficult than PICC insertions. Most of the PICC line training across the country was done on needle guides, and you can't do ultrasound-guided IVs with a needle guide, so you need the freehand ability. And I just brought in a fantastic nurse from another hospital by me who is a needle guide user. But I trained her in freehand, and she's fantastic. And what we need to do is that the companies don't tell you about the forearm because they only sell midlines. Our PICC line companies only sell PICC and midlines. Now they're coming out with the extended dwells. But we need to think of the forearm. We need to go there first if it's appropriate, and then work our way, to the more, bigger, larger vessels.
Absolutely. Amazing points. Is there a particular patient that really solidified the EPIV for you? You mentioned the sickle cell patient. Was that the one that was like, yep, or was there another one that really made you understand the impact of thermosensitive polyurethane peripheral?
So it actually, I have to admit that every day these patients just pull my heart right out of my chest. But a couple of days ago, we had a patient who, a young girl who needed to get blood draws and therapy. She's undergoing chemo, and her port wasn't working, and she was very, very thin, and her hair was all out, and beautiful child. And she was screaming. We had child life in there. We had the person who does alternative methods of relaxation in there, and she screamed and screamed. And one of the nurses had said to me, not in a callous way, this is how it always is with her. We just have to do it. And I looked at the whole room, and I said, well, we're not going to do it like this today. So I insisted that the attending give her medicine, PO. So we sedated her with that. And I said, look, I have a catheter that will make it one last stick for her. that we'll be able to draw blood, we'll be able to give her therapy, but we need it to be atraumatic. And when I put that in for her with all the same people came back in, we all tried again. The mother looked at me and cried, and she just said, "Can it be like that every time, please?" And I told her, I said, "I can guarantee you, I've been using this catheter for over a year. This will work. This will promise to make this the last stick for your child while she's here." And that is being able to believe in your product, I believe, is what makes the difference for me. I don't like to just put stuff in. I like to tell the family, look, I'm going to put a tunnel catheter in because this is the best thing for you. And I like to say, I'm going to put this peripheral in. I know it looks like nothing, but this is going to do everything for you. So yeah, that one got me.
That gave me goosebumps, Matt. That gave me goosebumps, and even a little teary-eyed. Amazing. Our patients shouldn't have to, a mom shouldn't have to be crying. And it's not just the pediatric patients, right? I mean, it's any patient. Just because you're big doesn't mean you have to put on your big girl pants or big boy pants and just suck it up, right? There really is better options. And as vascular access nurses, we can do better than what we're doing today.
I think so. I mean, I'll give you a quick example. I had an adult 2 days ago, dialysis patient, bilateral fistulas. He had absolutely no veins. I mean, the fistulas were in the forearm, the upper arm. He was hypoglycemic. His sugar was 11. He was in a ton of pain. And I took, because it was a code situation, not a code, but a rapid response, I took an extended dwell peripheral, an 8 centimeter, and I put it into his femoral vein so that we could give him the D50, give him the pain medicine, and then I used that to bridge to a mid-thigh-femoral catheter that I put in him an hour later. Now, I had gotten into a conversation with a colleague of mine who I respect to the moon, and he had said, well, why didn't you just do an IO? And I said, with the ultrasound, and maybe only vascular specialists can kind of have this edge. With the ultrasound, we can do anything, almost anything. And I just, being able to put an extended dwell IV in to get through a rapid response, to bridge yourself to the central line that you need, was another great example of being able to rely on this catheter and knowing that it was basically like a soft mini central line I was putting in without having to go through the whole rigmarole of a big sterile max barrier procedure to get through that rapid response and then save the day later. Win the battle, and then fight the war.
Yeah, absolutely. And, you take each one, each case is individual, right? Like some people, it's easy to say, we should do X, Y, or Z. But in that situation, when you're standing there, you make that decision at that moment and make what's best, the best decision for that patient.
And Connie, that's where our specialty is going. We are not technicians. We are practitioners that are making the best judgment call at the bedside at that time based on our skills and based on our tools. And that's what makes that, when I'm going back to my ER doctor that told me, Matt, you'll be so bored in vascular, there's not a day that goes by where I am not just wowed by what we were able to accomplish to these patients,
Yeah, we really are making a difference. That's for sure. Every single day, and everyone is grateful for what you bring. They really are. Your patients are grateful. Your colleagues are grateful, local and far, because you really are, impacting these outcomes. Real last question for you is there something that you would like, the listeners to know about your journey to reducing venous depletion for your patients? Any words of wisdom?
Yeah.
Because, we're faced with so many challenges, right?
Yeah, I think the biggest thing that I do with my team is that we are a team. We know what each other's strengths and weaknesses are. We know, we it's funny, we call it a Matt case or a Claudia case or a Jen or an Adrian or a Kate or a Tony case. And it's a collaboration. It's a collaboration between us to figure out what the best thing is. And what I would tell people out there is, don't be afraid to think. Don't be afraid to look at your patient, and if they're not crashing, don't be afraid to go, what else could we do? Is it possible? Come up with the idea and then find out if
Yeah.
it's possible, and then go through the process of making it happen. Because, everybody knows my little, thing over here, but when I brought the mid-thighs in to become not just a procedure for like extreme things, but as a standard of care at my hospital, that was a really big risk. But the impact that it has made here is it's just mind-blowing. And what it took was just me going, what else could we possibly do? So I would tell everybody out there, if we want to advance this specialty, just say what else, say why, and then come up with the idea. And if it's a bad idea, keep it to yourself. And if it turns out to be a brilliant one, then push it and teach us and share with us. We need to share with each other. When you came, Connie, to visit me, that was probably one of the most exciting days I've ever had, because I knew your name. I knew about you. And then I got a
That was
NICU
mutual.
baby. And then I had a NICU baby that day, and I said, you know what? I'm going to learn from Connie, and I want her to see, is there anything I need to know that I'm doing wrong or need to do different on my NICU babies? We need more collaboration. We can't just have the vascular team at this hospital and that hospital. We all need to come together, and not just at conferences. Like, attending the conference is one thing, but collaborating together, watching other clinicians do what they do is how we all grow. And I'm excited to tell you I'm going to go visit, and I know you just did too, I'm going to go visit Holly Hess in March.
Oh my gosh, I just was
Florida.
thinking, she is amazing.
Yep.
You gave me goosebumps again, twice. We so need to do these types of things, right? And have some ability to go and travel and see clinicians, because it's one thing when we talk to each other and like you said, you see each other at conference, but the opportunity I had to work with you was amazing. And I took that practice back to my hospital, and then to work with Holly, absolutely, you're going to love it. Her team is amazing, and yeah, they are just, I wish I could have videotaped, if that's a bad thing, but it's such a learning experience. And until you actually see these things, do you really understand and have the impact? So yeah, you're going to love it.
I think the biggest thing, Connie, is I thought that vascular access was vascular access. I didn't think there was anything more that we could possibly innovate with what we're doing. I mean, what else could possibly happen? And then every day I just say to myself, well, wow, I never thought we could do that. And then the next day, and I say to myself sometimes, all right, well, there's nothing else out there. And then just 2 days ago, I tunneled a catheter into someone's back, which is not new for interventional radiologists, but at the bedside, we don't do that stuff.
No, we don't.
So it was just such a great option and such a great realization to go, hey, why aren't we thinking about this sometimes? It's not that complicated if you're already putting in, jugulars, which, your team is doing and many others out there are. So, we're going to be so awesome as the years go on. I'm so excited to be part of this specialty. I'm so honored that you interviewed me for this podcast. And I just hope everybody out there just remembers, just ask, what else could we do for these patients, and come up with the ideas and change our practice.
Absolutely. Thank you so much, Matt. I really appreciate you taking the time today.
Okay. Take care, Connie.
All righty. Bye-bye.
Great, guys. Thanks so much for, honestly, listening to that and just hearing you two go back and forth and just talk about patients and the passion that you both have is really unbelievable to hear. Matt, I want to thank you again for taking some time out of your day to really just talk with us. What I hear and what I see is the passion that you have behind your work. And that is something that is just so great. And the ability to use that passion to help drive this industry forward, for allowing the conversations that people are going to have tomorrow because of the work that you're doing today is really where your impact is going to be. And to be able to push those boundaries a little bit and try what is best for patients. I think that you really can hear the work that you do is so patient and centric and patient focused, doing the right thing for their patients and their specific needs. You can tell you really do assess each patient on an individual basis and really truly pick what is best for that patient. And I think that's what it's all about. your institution, your patients, and everybody are very lucky to have you and to be able to benefit from the work that you do. So thank you so much for sharing those stories, for sharing your work with extended dwell peripheral IVs, and for everything that you do for our industry as a whole. I really do appreciate it. I know that we are very thankful that you were able to join us today. I also would like to take just a quick moment to say, if you don't follow on Facebook, the Vascular Access 365 group, you really should check that out. Matt has started and just talks about products in a non-biased way, where he just lets clinician to clinicians have conversations about what they do. So please check that out. It's, again, Vascular Access 365. I also hope that you will continue to check us out and follow our podcast. You can find them at bygoneusa.com, reducingvenous-depletion.com, and our LinkedIn and Twitter accounts. Thank you so much, everybody, for joining us, and please stay tuned for the next podcast, as we have some great ones coming up. Have a great day, everybody. Thanks again, Matt and Connie. Bye.